But in other places, often because it's patients are looked after by non-IBD specialists who fail to read what I sometimes call the writing on the wall, then there are still people, young people, who die from acute severe colitis and often the complications of surgery which has been too long delayed. And what about response to steroids? So look here, this is work from Dan Turner looking at all 32 trials, not many of them randomized, not any of them randomized, not many of them prospective, but and some with cyclosporine and some without. And you can see that the colectomy rate here, which is the red bar, has been constant all the time from 1970 to 2005. And the first randomized controlled trial in gastroenterology was actually by Sidney Twiller back in Oxford in 1955. And I've highlighted the colectomy rate in the Oxford cohort at our different publications, and you can see it goes straight along the fall line. You know, we don't have a high colectomy rate; it's absolutely in the median level, and that unchanged for 40, 50, 60 years. It is quite notable. How can we improve response to steroids? Perhaps we should give them more, and sadly that doesn't have a difference. There are a whole series of different steroids. I'm not going to go through that, you'll be glad to know. Different doses, mega doses of steroids, and guess what? When you actually put them all together and you use a steroid equivalent, which is what Dan Turner did with Anne Griffiths and Hillary in Toronto. Take all of those, so you make an adjustment for their potency and weight, and actually you can see that the dose, if you equivalent, whatever you go up to, there's again absolutely no difference in the colectomy rate. So the dose of steroid doesn't seem to matter, the type of steroid doesn't seem to matter, and I was quite amused when I was looking into this about the number of steroids I'd never even heard of. There is a website that you can use to calculate equivalent doses, and if you look at the various ways that steroids have been combined, look at how underpowered all of these studies are and published. Actually, they're all over the place. There's nothing there that steroids, different types of steroids, improve the response. So steroids have done a great job. I would still argue they still remain first line, although I think that's going to be increasingly challenged. But they do no more today in 2011 than they did in 1955, and we shouldn't ever expect any difference. So what do? You can behave like an ostrich. Put your head in the sand, keep going with steroids, cross your fingers, and hope things will be all right. You can go straight to colectomy, but no patient I've ever met wants a colectomy, although sometimes they're not entirely sure what is best for them, but we might come back to that. You can use cyclosporine, you can use infliximab. Operation, as I've already mentioned, to save lives. It was the changing the threshold that Sidney Truelove did in changing the threshold for surgery, which made a major difference. And this rather complicated paper in the British Medical Journal a few years ago looked at population-based data on the mortality after patients had been admitted with an episode of colitis that had led to colectomy, and looked at it over the following 3 years and related it to the standardized mortality rate in the general population. And you can see here the patients who had an elective colectomy had a definable mortality, early mortality, which then remained stable. And you can see here in the red, sorry I don't have a pointer, you can see in the red the patients who were admitted as an emergency and had a colectomy had really quite a substantial mortality, nigh on approaching 10% there, which I hope wouldn't happen nowadays, but it's still much higher than we as physicians or surgeons hope. But then having had that emergency colectomy again, early mortality, and then it remains stable. But look here, it's this blue group, the people who were admitted with ulcerative colitis in emergency, avoided colectomy, and look at that cumulative mortality over the following 3 years. So what's going on there? Well, it seems to me this tells us that emergency colectomy is high mortality, and therefore we've got to say, how do you make that safer? And you've got patients with acute severe colitis who avoid colectomy. They've got a cumulative mortality, and one suspects that's because they're sort of delayed surgery. They come back in delayed decision making. And we've looked at our outcomes in surgery for acute severe colitis, and glad to say in all of our publications that we've not had a death, but saying that is a hostage to fortune. We published this in the British Journal of Surgery a couple of years ago. And in patients, we wanted a substantial follow-up for between, this is really the pre-biologic era. And all treated preoperative surgery, 30% had cyclosporin, and followed up for 5 years. And the only factor which predicted post-operative complications, the complication rate was high. There's no getting away from if you have an emergency colectomy, you've got a high major complication rate over the following 5 years. That's a cumulative complication of intestinal obstruction, ileostomy dysfunction, or whatever. The only factor associated with it on multivariate analysis was the duration of medical therapy prior to surgery. And that, to me, sort of sends a message to physicians. It's us physicians, rather. Sometimes sound like speaking like a surgeon. Us physicians who make complications for you surgeons, wherever you are, or some surgeons. And I think that it is a really, really important issue. So we as physicians have got to move that decision-making to the left and try and reduce the post-operative complications, because that is the outcome that absolutely matters. So how do we do that? Mark Lamar sadly died last year, and Jack Sasagi and myself have just reviewed earlier on this year in Gut all the critical factors, and goodness gracious me, lots of attempts have been tried to read the tea leaves and polish the crystal ball for looking at the future. And you can see here, maybe you can't see very well here, all the different clinical, radiological, biochemistry and factors which have been looked at, all the different studies, and these are all the retrospective studies. Here are the prospective studies where we've taken often fairly small cohorts of patients. Ours in Oxford in 1996 had 49 patients and 51 episodes, and looking at clinical factors and then relating that to the outcome and to colectomy. And we came up with a number of observations. The first is that the numbers of additional true love and wits criterion for these measures of severity, these clinical and laboratory measures of severity, on admission is associated with outcomes. So there are the true love and wits criteria to remind you up there. And if you've just got one additional criterion, in other words, you've got blood stool frequency, that's the foundation, and you've got either a tachycardia, temperature, anemia, or a high ESR, then if you've just got one, then there's a 9% colectomy. If you've got two, it jumps up to 31%. If you've got a full house, 3 or 4, then it's approaching 50%. Numbers, of course, get very small there, but the message is the biological severity on admission is a way of early warning signs. Now, I'm not suggesting for a moment that decisions are made on that basis, but it doesn't half make a difference to how you approach the patient and how you manage their expectations, because it's all about contingency planning. And back along 96, we produced this Oxford index, which, if you're producing indices, please just make them simple. Ones that even those of us without a mathematical brain can remember. And it was great when this broke, that